Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we're back with another primary snippet. It's been a long time, so how are you, Maddie?
I'm good. It's been busy. We've moved house, which has been exciting, but a lot of work. And yeah, just otherwise looking forward to when winter will be over.
Maddie, can you please outline the process of fibrinolysis and describe the mechanism of action and adverse effects of Alteplase?
Sure. So fibrinolysis is the process of clot breakdown, and it consists of a series of proteolytic enzymes. This whole process helps to prevent excess clot formation. So the main mediator of fibrinolysis is plasmin, which is an enzyme that cleaves fibrin, resulting in fibrin degradation products. Plasmin is produced in the liver as an inactive precursor called plasminogen, which circulates in the bloodstream and binds to fibrin through lysine residues, but it cannot cleave it. So when endothelial cells are injured, they express tissue plasminogen activator, or TPA, which binds to the plasminogen fibrin complex and activates the plasminogen, converting it to plasmin, which then can degrade the fibrin. TPA is synthesized and released by endothelial cells and is the primary activator of plasminogen. The affinity of TPA for plasminogen is increased significantly when plasminogen is bound to a fibrin clot. Factor 12 is also activated by exposure of the subendothelial matrix proteins. This forms a complex with high molecular weight kininogen, or HMWK, and prekallikrein. It then activates kallikrein from prekallikrein and bradykinin from HMWK. The bradykinin induces TPA release from endothelial cells and also the release of nitric oxide and prostacyclin from endothelial cells, all of which are platelet inhibitors. Factor 12A and kallikrein also activate plasminogen, but less potently than TPA. Plasminogen is also activated by urokinase, which is a protease produced by macrophages, monocytes, and urinary epithelium. Urokinase has a lower affinity to plasminogen compared to TPA, but does not require fibrin as a cofactor. Both TPA and urokinase have short half-lives of 2 to 4 minutes due to the presence of specific inhibitors of fibrinolysis. So there are inhibitors of fibrinolysis, and some of the more potent ones are plasminogen activator inhibitor 1 and 2, thrombin activatable fibrinolysis inhibitor, or TAFI, and alpha-2 antiplasmin. So plasminogen activator inhibitor 1 and 2 inhibits TPA and urokinase. They're produced in the liver and stored in alpha granules in platelets. They're produced in excess of plasmin and bind to endothelial cell expressed TPA, but have limited ability to inhibit TPA, which is bound to fibrin. Thrombin activatable fibrinolysis inhibitor, or TAFI, is activated by thrombin binding to thrombomodulin on endothelial cell surfaces. It cleaves the lysine residues in fibrin, which prevent plasminogen binding. It's synthesized in the liver and also found in platelets. TAFI is activated weakly by thrombin, but very strongly by thrombomodulin complex. And finally, alpha-2 antiplasmin is the main inhibitor of plasmin by forming complexes with it. However, it is less effective when plasmin is bound to the fibrin clot. Factor 13A cross-links it into the fibrin clot, which renders the clot resistant to fibrinolysis. The coagulation pathway and the fibrinolytic pathway are activated simultaneously when there is injury in order to avoid excessive bleeding or clotting. Endothelial damage stimulates the clotting cascade rapidly via collagen exposure and thromboplastin activation, but also stimulates fibrinolysis through the slow release of TPA. That's all a lot of information, and it's quite difficult to understand just, listening to it or in text form. So if you do look at the show notes, there is a diagram that does sort of briefly show some of the interactions between the coagulation cascade and the fibrinolytic cascade. But it's important to know that there's a balance between the two, between things that form clots and things that are trying to break up clots, and it'll depend on the situation which is more active. So then coming to Alteplase. Alteplase is also known as recombinant TPA. It converts a small amount of plasminogen to plasmin in the absence of fibrin, but where there is fibrin clots, Alteplase binds to fibrin and cleaves the arginine-valine bond of plasminogen, which then converts it into plasmin. The plasmin then degrades, promotes clot dissolution. Alteplase initiates local fibrinolysis with minimal systemic effects. So the adverse effects of Alteplase includes obviously the augmentation of the drug's action. So this can cause excessive bleeding. It can also result in transient hypotension, allergic reactions such as angioedema, anaphylaxis, rash, and bronchospasm, fever, and very rarely it can result in cholesterol embolism. If you want more information or more references, there are some references in the show notes of this primary snippet.
Thanks, Maddie. So that's very comprehensive answer. So that's the end of our today's snippet. We'll be back with another snippet in a week's time. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.